Dear Evan Hansen, today is going to be an
I am not a stranger to the dark. Hide away, they say, 'cause we don't want your broken parts. I learned to be ashamed of all my scars.
This is me. I just love that song. I love it. I love it. I love it. I love it. And welcome to Chat and Chew. Chat and Chew. Yes, yes, yes. Let me catch my breath here a little bit because I got so involved in the video. As first time I seen the video, I was like, wow, okay. It's awesome, awesome. But the more I think about that song and I think about Pride, and it's like, all righty now. All right. So, good afternoon, family, and welcome to Baltimore's Chat and Chew. Chat and Chew is a ministry of MCC Baltimore and is an interview show that normally is seen on the first Sunday of the month between 12 noon and 1 Eastern Standard Time. We will discuss topics concerning the LGBT plus community and our allies. It's called Chat and Chew because we'll be snacking while we're talking, creating an atmosphere of intimate conversation over our kitchen table. And before we get started, let's say a prayer. Oh, Heavenly Creator, Lord, we just thank and praise your holy name. We thank you for the ability to use the airwaves to promote life and love. And we thank you for the gift of Simply You. Be with us, be with the technology, and with one another. We humbly ask this in your most precious name. Amen. Amen, amen, amen. So today we have a very, very special guest. Special because she she's in California and got up early, this morning just to be with us here at noon. And I'm so excited about that. Her name is Molly Karras, like Molly Cyrus, Molly Karras. And we're going to be talking about reducing infections and HIV infection in the LGBTQI plus communities. All right, so please welcome to the stage Dr. Molly Karras. Hey, Molly.
Thank you. Hi, thank you so much for inviting me. It's a pleasure. I'm glad. I have two kids, so I get up early, so no worries about that. They wake me up first thing in the morning. Hi, I'm hungry, Mom. I need breakfast. But again, thank you so much. Just a little bit about myself. I'm an associate professor at the University of California, San Diego. I currently live within the divisions of infectious diseases and geriatrics. And that's because my main clinical and research focus is in caring for older adults with HIV and older adults who are at risk for HIV. So I love talking about this topic. I love talking with the community. Hopefully, like this will be very informative and helpful for you. And please feel free to ask questions as well.
Cool. When I first saw the clip and I was looking at it, it never really occurred to me. I don't know why it didn't occur to me about HIV infection, particularly in older communities, because I knew it was always a thing. It was a thing in the 80s and the 90s. My mom used to live in a senior citizen high rise, and in visiting her, I got to witness why the infection rates were so high. So what we're going to do before we really get started, we're going to watch the clip. And after we watch the clip, and then we'll go into our conversation.
Hello. For those of you who do not recognize me, I am not Nicole Kidman on anabolic steroids. No, I am not Ariana Grande's grandmother. No, my name is Varla Jean Merman, star of stage and screen. And I know recently we have been inundated on ways we can stay safe from the coronavirus, right? Oh, here, just in case, don't get too close. I mean, in fact, over the past several months, I have absorbed so much antibacterial soaps, so much antibacterial lotions and disinfectants that now when I pee, I'm actually cleaning the toilet. I'm kidding. I don't clean the toilet. Well, my friends over at DKB Med, they wanted to make sure, however, that we weren't forgetting another virus. You remember her, HIV, and specifically how it affects people who are aging in the LGBTQ community. Well, I am so excited about my guest today. I'm literally kicking up my heels. Yes, he is a clinical nurse educator, and he is the eHIV Review Program Director. Let's give it up for Justin Alves.
Thank you so much for having me, Violet.
Oh, wonderful. You know, I'm shocked to see you dressed so casually, but I guess you didn't get the memo that this was a formal meeting, but don't worry about it. Don't worry. Now, those of us who are aging in the LGBTQ community, and let me tell you, you know who you are. Do we still need to be screened for HIV? I mean, why is that even important now?
Well, I mean, I always think it depends on what you're doing, right? So if you're one of those people who's sort of aging gracefully, screening is really important still. If you are continuing to have a sex life, if you are continuing to maybe still use drugs, you're still at risk. And we should continue to try and screen to catch things early and really get people engaged in treatment quickly.
Okay, well, how can HIV be prevented? I mean, do we just have to have sex 6 feet apart, or just wash our hands for 20 seconds before and after the deed?
Well, I think washing your hands is probably a good thing, but that's not going to stop HIV. I think what's really important to remember is some of the good sort of old school things that we used to do still apply, right? So using condoms, getting tested before you have sex, those are all good things to do. But we have some new things now that we haven't always had in sort of our toolbox. So things like PrEP or pre-exposure prophylaxis is a really great option for some people who maybe aren't as good with the condoms as other people.
I see. So let's say I do get screened and I find out I have HIV. I mean, what do I do after I stop screaming?
Well, hopefully you're not screaming too long. Hopefully there's somebody there to sort of comfort you and help you, maybe a nurse, a fabulous nurse like me. But I think one of the things that we want people to do is get on medications early. And we want people to get their viral load, that's how much HIV virus is actually in their body, down to an undetectable level. And we want that to happen because we know it's good for you. It's going to improve your long-term health outcomes. But it's also good for everybody else because we know that when people are undetectable, they're untransmittable. They can't give someone else the virus either.
Justin, because I am so brightly lit right now and my image is so heavily filtered, many people may not realize that I am aging. Yeah, sometimes it even makes me raise an eyebrow. And look, I can't. I'm trying as hard as I can. But what are some things impacting aging adults who are living with HIV?
So I think the things impacting aging adults living with HIV are similar to the things impacting aging adults not living with HIV. So things like social isolation, feeling alone and not having people your age to hang out with or be around. But then there's some special things specifically around HIV. So things like polypharmacy and things like lipodystrophy.
What? Polypharmacy? Well, sounds like a great drag name. Ladies and gentlemen, polypharmacy. I'm kidding. What is polypharmacy?
Well, polypharmacy is not as complicated as it sounds. It literally just means many drugs, right? So people living with HIV might have lots of different other conditions when they get older, and they might need to take lots of different types of medicine. And so the more medications you take, the more complicated it gets.
Well, what is lipodystrophy? That's not really a good drag name. Doesn't really roll off the tongue. What is that?
So lipodystrophy, if you think about it, liposuction, right? You take out the fat. Lipodystrophy is when fat gets distributed differently. So people living with HIV, as a side effect of some of their medication, can actually have less subcutaneous fat and more visceral fat. Essentially what this means is you can get kind of like a belly from taking your medications. And then you can get some skinny arms too. So just a redistribution of the normal fats we have in our body.
Okay. Well, HIV has been around a long time. So what are some issues underexplored in people living with and at risk for HIV?
The issues underexplored by providers related to HIV are the same things that they were back in the 80s. People don't want to talk about sex and drugs. People definitely don't want to talk about sex and drugs with people who could maybe be their parents' age. And so sometimes advocating for yourself to talk to your doctor or your nurse to say, you know, I'm doing these things or I'm having sex with these people is a huge, huge important part of taking good care of yourself as you get older.
Okay, Justin, I don't mean to change the subject, but let's talk about someone who is newly single. It's not right, but it's okay. Little Whitney Houston reference. What advice do you have about someone who's single, who's, you know, getting back in the dating game? And by dating, I mean getting my freak on. That's what the kids say.
Well, you know, being single myself, I'm not sure how much advice I actually have about the dating game if you're looking for a husband. But if you're looking to be single and get your freak on, as you said, I think starting to learn some of the lingo that people use on some of the apps is super helpful. Know what drugs are, know if you're going to use them or not use them, and know how to keep yourself safe when you're having sex. So are you going to use condoms? Are you going to use PrEP? Or is your partner undetectable and that's okay too?
Are there any other topics that we forgot?
I think the one thing that always comes to mind whenever we talk about HIV is stigma. Stigma for the people living with HIV and people who might be afraid of getting HIV from them, even though we know undetectable equals untransmittable. And then we also have the stigma of providers, right? So if you have a lot of other medical comorbidities, there's specialist doctors who maybe have never taken care of a patient with HIV before.
What are comorbidities?
Yeah, comorbidities can be complicated, but it's essentially more than one disease happening in one person at the same time. So sometimes that can happen because people have multiple diseases. Sometimes it can happen because a medication might cause a side effect that leads to a different type of disease. So some comorbidities we see in people living with HIV are things like heart disease and renal disease and bone disease. And sometimes we can actually change people's medicines to something much simpler and safer.
Oh, thank you. Thank you, Justin Alves, for talking with me about HIV and the aging LGBTQ community. So remember, protect yourself and protect the ones you love and play safe. This has been Varla Jean Merman. Unlike me, this never gets old. Right?
Oh, I must admit, that's like the fifth time I watched that clip, and it really gets more and more funny to me. You know, it brought up several questions. It really did. But the one question I first wanted to ask you, and which you probably, I don't know if you know or not, um, since we're in the age of COVID, is there an increase in infection rates for seniors?
So we don't know that yet. You know, I think it's really too early. Unfortunately, to compile data like that often takes a couple years. So our statistics are usually always a couple of years behind. Particularly if you want to look at the nation. We're starting to get some information about COVID and HIV from single centers. So, you know, a hospital has an experience and they report it in the literature. And then we can kind of extrapolate from that. So it does seem that at least men who have sex with men were having less sex during the pandemic, or at least less sexual partners. I think people were being, in general, a little bit more careful with, you know, like gathering in large groups and meeting a bunch of different people. But at the same time, access to care, so access to both HIV care, treatment, labs, medications has also been diminished. And that's something I think that we've seen across the board. You know, initially when hospitals were closing, at least at our hospital, we went only to virtual appointments and nobody could come in for a couple weeks. And then we slowly started changing that. But patients were also uncomfortable about coming to the hospital where there are all these people with COVID. They didn't want to come and do labs. So, you know, certainly a lot of those services were also delayed. And because of that, it's possible that there are some people who are living with HIV that weren't taking their medicines as well, just because of access issues. And as we heard, you know, undetectable equals untransmittable. If you went a month without your meds because you couldn't get it, your HIV viral load maybe went up a little bit and you had unprotected sex, that potentially could have led to a new HIV infection. Similarly, we also know that PrEP or pre-exposure prophylaxis prescriptions decreased during the pandemic. And again, if you were on PrEP and you're very sexually active and then you couldn't get it anymore, then that person may also be at risk. So overall, I think we just don't know. Although there was a recent article that seemed to suggest that because people were coming in more often because they're worried about COVID when they had symptoms, that they were able to actually diagnose acute or recent HIV at a much higher rate than like their usual baseline. So just like any other virus, within the first month or so of acquiring HIV, many people will present with like fevers, fatigue, rash, headaches, the usual generic symptoms. And if they had that, they may be worried they had COVID, so they go in and get tested for COVID. When COVID tested negative, this one system looked for other causes. And so they also were doing routine HIV testing already. And so they found many more people with recent or acute HIV because they were coming in to get tested. So, I don't know. I personally don't think we're going to see increases just because I think in general, people were more cautious about taking risks with folks, but we won't know that just yet.
Okay. I hope that is truly the case.
Yeah.
Back in the 90s, I used to do HIV outreach in seniors and senior buildings, and I was really amazed. My mom lived in one, so senior buildings to me was like my mom's home. I didn't really think people had sex in there, and then I realized, particularly at the first of the month, because seniors are who they are and the way the culture treats them, a lot of times our seniors are kind of housed away in senior citizen buildings, and they don't get a lot of they don't get a lot of visitation. And so even, I guess for lack of a better term, negative visitation is better than no visitation at all. And by negative visitation, someone whose time you have to pay for. It beats a blank. It just honestly, after talking to a lot of the people, a lot of singers in there, it beats a blank. The only time they got visitors was when the first of the month when the checks came, and the people who wanted the money from the checks came, and they traded resources.
Yeah.
And I just found that really really interesting, because in Baltimore, I think the average person who's infected with HIV is a senior. Is a woman who's Black, who's 50 plus. And chances are she lives, in a high rise. And it was like, wow, it's just really amazing, that these are the groups. And with COVID, with the thing of COVID, which to me seemed to add more isolation. That's why I was asking the question. I was like, oh, this really was, I think the numbers are really going to skyrocket.
Yeah.
But that was the reason why I asked the question. I also wanted to know, lost my questions. Could you explain, because I know he talks about a PrEP holiday. What exactly is a PrEP holiday?
Yeah, so pre-exposure prophylaxis, for those who are not aware, we now have medications that you can take before you get HIV to prevent you from getting HIV, kind of like birth control, but for HIV. And it's basically two drugs. There's currently 2 approved pre-exposure or PrEP treatments, and it's meant to be taken every day. So in order to keep the drug levels high enough in your blood and in the genital tissues that might get exposed to HIV, you do need to take it almost every day. Unfortunately, if you're a woman, you do need to take it like 6 out of 7 days. If you're a man, you seem to be able to get away with taking it less and still have protection. So there's some sex differences with this, unfortunately. But a PrEP holiday is basically when, like say you're in COVID and you're like, I'm isolating myself. I'm only gonna like, Zoom people. I'm not interacting with anyone. I don't want to keep taking this medication because I'm not gonna have sex. So then you just stop it. You just stop taking your PrEP. Usually as a physician, we recommend that you take your PrEP up to at most like 30 days, after your last sex encounter to kind of protect you from that period. But that's a very conservative counseling, probably you could take it a week later after your last sex and it's okay. But usually we still say 30 days.
Mhm.
So that's basically like what a PrEP holiday is. It's just taking a break from it.
Okay, cool. Also, I think one of the things I think because of having to be in research or working in research, my view is kind of different from most people, and I'm really amazed at how people really don't share their medical histories with their doctors. You know? So how can we make that happen more?
So I can say we're trying on our end to better educate at least our young doctors and our older doctors that are interested in getting better about talking to like patients about what historically would be maybe considered taboo issues like sex and drugs. Um, and unfortunately, I think you had kind of alluded earlier, because of ageism or just this
Mhm.
idea that like older adults are like my grandma and they don't have sex and they don't use drugs, that doesn't happen. Because of that, I think they're particularly at risk of never being asked,
Mhm.
and never being educated about what the risks are for both of those things. Certainly I what I could say, and this was also kind of talked about a little bit in the video,
Mhm.
being your own advocate is important, because your doctors are probably not going to ask you unless you have a really good relationship with your physician or they are particularly interested in the area of like LGBTQ sexual health or substance use.
Mhm.
Um, and I also recognize though that sometimes even broaching the idea with your doctor can be a traumatic experience. I mean, I see a lot of older adults for PrEP who came to me because their doctors, when they tried to talk to their doctor about PrEP, their doctors were very negatively reactive about it. And one of my patients said that when he told his doctor that he was bisexual
Mhm.
and wanted to go on PrEP, he said, I disagree with that. I think you'll die from HIV if you go on PrEP. And I mean, and that's just one example, but there's
Mhm.
many unfortunate examples of that. And we're in Southern California, we're supposedly a liberal area, and yet still people are having these experiences. So I think what I recommend is maybe number one, definitely talk to your doctor about these things,
Mhm.
but potentially prepare your heart ahead of time if you don't get an answer from them that's supportive. Sometimes, like you can even offer it up and say, Dr. So and so, my sexual health is an important part of my overall health. And I'd like to be able to talk to you about it. But if you're not comfortable, would you be willing to refer me to someone else? So, kind of even giving them an out,
Mhm.
just in case they're just like, they cannot deal with it. Substance use is another issue. Like I think it's very difficult. So that there's stigma around the LGBT community, there's stigma around HIV, and there's stigma around substance use. And having those conversations, I think, are often very difficult with your doctor. And I can't begin to predict how your doctor would react. But I think it's very important for lots of different reasons. So, number one, like I said, I don't think doctors don't believe that older adults are using substances. And they're not likely to ask you about it unless something happens, like you present with a stroke or something
Mhm.
catastrophic like that. Um, Treatments exist currently to help people to achieve and maintain sobriety, or at the very least, harm reduction. So, if you're not ready to stop, there are things that your physician can help connect you to or provide for you that will make it at least a little bit safer. So, like, if someone uses heroin, having naloxone on hand that could reverse the effects of that, and teaching the people in your family or your small community how to use it correctly that could be something that's very life-saving. That's something that you should have on hand. Needle exchange and things of that sort. There also may be some interactions with prescription medications and substances that people don't think about. And, as we all get older, we unfortunately accumulate more and more of these medicines. And the more you have, the more you're at risk for these interactions. And there are also some other, health risk and screening tests that your doctor may not normally do for you unless they were aware of some of these risks. So, I'm hoping that this kind of pushes you to talk to your doctor, try to broach the topic with them. Sometimes it helps to bring a friend, it's hard because unfortunately there is still this power differential to some degree, with a physician and a patient. And I've seen it on the other side, how some doctors treat folks that use substances. So I understand that this is difficult, but I do think it's very, very important for senior health.
True. And I've also noticed that, being now an older person, I'm always amazed at how my own nieces and nephews somehow think I know absolutely nothing about sex. I just marvel at that sometimes, just like, I don't know if they thought at some point lightning came and just struck me down. I don't know. But one of the things that I think, families in general just have to do is just have these conversations and make them ongoing conversations. One of the things that I do in my family, my nieces would say, unfortunately, whenever they bring someone new to the Thanksgiving table, I ask the uncomfortable questions, because I'm thinking that if I ask the uncomfortable questions, it will get them into the habit of asking the uncomfortable questions, and then they'll get used to knowing what the answer is instead of like, oh my God, oh my. I usually ask, when was the last time when was the last time you got tested for HIV? And did you get the result? And usually when I ask that, my nieces usually die, because
Yeah.
I have 12 nieces and one nephew, and they all just sit around and just wonder, why can't I be like the other uncles and just sit in the corner and play spades or something? But I really think we as a culture, as a society, as a group of people, we need to just start talking about sex. I mean, it's a natural thing, no matter what the orientation. And we need to know how to protect ourselves. And we need to be able to pass that communication on to our physicians. And the only way we can do that is when we start really getting comfortable talking about things.
Yeah, no, I agree. I think you'd said earlier that a lot of the infections in HIV are in older women, in your area.
Mhm.
And I think a lot of that has to do with just this imaginary stigma or idea about like who gets HIV. Really, if you've had sex, you should get an HIV test, because you cannot know, like for sure, what the risks of your partners are. I mean, I've so many examples of people that would not be considered an HIV risk. People that I care for, like that, thankfully, some of them got just tested routinely and they found out, but others unfortunately had to get really sick before they were tested because they just had no idea,
Mhm.
including, like 40-year-old women with 3 lifetime partners. That's not risky. That's maybe even below average.
Right.
Or the 18-year-old that only had sex with his high school girlfriend. It's like, there are, I do think that is something that we do need to talk more about sex, and we need to kind of destigmatize this idea of who's at risk, for these different sexually transmitted infections.
Mhm. I truly think we need to, because I really thought HIV would have been gone by now, and thankfully, from what I hear, because of COVID research, we're getting closer with HIV research. Um, One of the questions I also had about PrEP: can seniors access PrEP like on Medicare, Medicaid?
Yeah, so maybe is what I'll say. So Medicare C Parts D and C do cover PrEP prescriptions, but it differs. Your cost, your share of cost is different, and it may be cost prohibitive for some people. And sometimes Medicare will cover, the prescription, but they won't cover the every 3 month testing that
Mhm.
usually goes with that prescription. So it can be complicated. At least to help with the drug costs, the pharmaceutical company that currently is the only maker of the two different types of PrEP, they do offer some patient assistance programs so that it can be a little bit more accessible for folks that have a really high coverage or like a big deductible. So that can be an option, but it can be difficult for those reasons.
Mhm.
It's common enough now that I think many primary care doctors feel comfortable doing it. It's not that difficult. I think the most difficult thing is probably talking about sex for primary care doctors. So it should be more pretty widely available at this point in the US. It's just, how much share cost is unknown.
Cool, cool, true. I'm glad that we're making it affordable, or we're getting to a point where it's becoming affordable because um, before I started a relationship, I was on PrEP, and it was thankfully because I worked. It was my insurance picked it up, but I kept thinking again, and thank God I have a great doctor. Because I thought I asked the questions. My doctor is awesome in asking me a lot of questions. She really drilled. She really drilled me, and I was just amazed because it was the first time I've ever had a sex talk like that before.
Mm.
Because in my head I was just thinking, okay, LGBT, this is the drug for me, and and she really made me drill down to exactly what was my risk, and how when was I having sex and how, and I was really amazed again, that I was having that kind of conversation with my doctor, because a lot of the things that I assumed I knew about PrEP, I didn't.
Yeah.
I just naturally assumed, since I was sexually aware, I mean, since I was sexually active, that this was the drug for me. And then after about 3 months, she asked me about my relationship twice. And then she was like, so why are you still taking it? And I was like, not to say for general audiences, again, it depends on what's going on in your relationship. But I think we know those are conversations that we need to know from our physicians. And I'm very grateful for you, Molly, because I've worked with some who they don't they know it's there, but they will not mention it. I was just out of curiosity, do you know of any senior programs that um, encourage conversations, or I'm trying to figure out how can we help senior.
That's a really interesting question. I don't, so I know that there are some Facebook groups, of older adults. So there are some support groups that exist that have kind of naturally formed.
Mhm.
So I know that there's a couple of special Facebook groups where people can kind of get together and talk about, some of these things and learn from each other. But I don't know of any specific program apart from maybe Gay Men's Health in New York probably does some of this work. I imagine that this is something that because they've been focused on aging with HIV for a while too, and they're big advocates. APLA on our side on the West Coast is another big organization that does a lot of education and advocacy work
Mhm.
for the community. But this is I think you should start something in Baltimore. This is a great idea, like teaching
Mhm.
patients how to speak to their doctors so that they can actually talk about sex and substance use and in a way that their doctor is not freaking out and judgmental, or even providing support, like having maybe a member from the church go with them to have that conversation with the doctor. That sounds like a fantastic idea. I
Mhm.
love it.
Yeah, I was also thinking like for churches who had like senior programs like Sage, I ain't mentioning no names.
Sage, yeah. Sage is good too. Sage is good.
It would be interesting to make sure that we had those talks with those people, with those senior groups, or any group actually, to make sure that they are aware of the information and the stuff that's out there. Because a lot of times people just assume that everyone knows about this stuff, and many people don't, and it's really strange.
Yeah, and I think it's not the people who are coming to the clinic a lot, right? It's folks that live maybe more far out or
Mhm.
rural that are just not as engaged with their physician. I think that really might benefit from some of these things and they just don't know about them. But yeah, those are folks that maybe are coming to church or going to other activities or just not seeing their doctor a lot. It's a great place to begin that education.
Cool, cool, cool. All right. Um, I know we talked about sex and we talked about drug use. Are there any particular places other than about, or is there anything about senior living that make these two come together?
So yes. So I think in general, I think of sex and substance use as being kind of part of factors that either benefit or impair healthy aging. So I'm a big proponent, even though I'm a prescribing provider, like I'm a big proponent of addressing these modifiable lifestyle factors that negatively impact health. So, for example, like inactivity, substance use is another one, tobacco use, too much alcohol, loneliness and social isolation. These are issues that your physician doesn't normally address because we don't have medications for them. Unfortunately, the way that doctors are trained in America, it's to diagnose and prescribe and not necessarily to kind of help people as they're navigating some of these really difficult parts of their lives. Social isolation, like you said at the beginning, even before the pandemic, has been a major issue for older adults and younger adults too. Um, and I think, but doctors don't know what to do about it because we don't have a pill for that, and we don't know. We can tell patients, oh, maybe you should find a support group, and they're like, well, what support group? And we're like, oh, we don't know, because we don't do community stuff. Or some of us know, but a lot of doctors are not aware of what's available, or and I think even within the church, it can feel taboo to talk about some things. And so some people may be very involved in the church, but still feel isolated because some of the things that they're going through, they don't think that they can bring it up because of, I don't know, their own personal ideas of what
Mhm.
the church should be or a Christian should be or whatever. So yeah, I mean, I think they kind of fit into this like choosing to uh, pursue these positive lifestyle things like exercise and an improved diet and connection. Substance use and sex kind of go into all of that.
Hmm. Some of those things I never thought about. I was all of a sudden thinking about a wellness course or an exercise course, and making just having talks during an exercise course would do a lot.
Yeah.
Thank
Yeah,
you. Thank you.
I think we are, so there's a couple clinician researchers in this HIV and aging world that all think very much the same. We've thankfully found each other. And we're all doing different things in our own way. I have a colleague in Colorado that's really big on developing exercise programs. My specific interest is in isolation and loneliness. So we are developing some connectivity programs here for our community. But yeah, I mean, all those things. I think wellness is a great approach to aging. Aging doesn't have to be decline. Aging can can be celebration of like your life, ongoing successes, and pinnacle of health.
Very true. Very true. That awesome. 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 Mm. I'm looking at my list to make sure I covered everything. Oh, also, because although we're talking basically about seniors, I mean, HIV infection is knows no age, and truly knows no age. I think my question is because I'm thinking about doctors and medications or whatever. Um, oh, that's what it was. How are we getting with HIV medications as to not necessarily as a prophylaxis, but more as a treatment? Are we getting, as the medications are getting better or no?
Yeah, so I will say in overall, yes. So,
Mhm,
compared to the 80s and 90s where people literally had like handfuls of pills that made them so sick that they had to take more handfuls of pills for all the
mhm,
side effects. That is better, so for those that don't know, the standard of care now is one pill once a day. Most people are able to do that. There's a couple of folks, unfortunately from the 80s and 90s, because they were just given one pill at a time, because we didn't know, back then that HIV would develop resistance. There's a handful of folks around the US that still need to have more complicated regimens, but the
mhm,
majority of people with HIV today can get away with one pill once a day with very minimal side effects. But the future, I'm actually very excited about what's coming. So we
mhm,
have our very first long-acting HIV medication. It's basically 2 shots once a month. The company is currently trying to go for every 2 months.
mhm,
So if they get that FDA approval, it would be 2 shots every other month, instead of having to take a pill every day. So that's the first of our long acting. There are several other long acting medications in the works right now, both oral and shots. So there's one medicine that is currently in development and being evaluated that would last in the body for 6 months. So it'd be like a shot every 6 months. The issue with that is we have to find a partner for it because you can't just give one HIV drug at a time. So I think they're looking to find another similar drug that, maybe we could do like twice a year shots for HIV. That's it. I mean, that would be amazing. And I mean, there's even some, and so orally, they have some pills where you can take one pill a week. Like again, they're looking for partners for these medicines, but instead of having to take it a day, just take it on a Sunday, like easier, right? So I
mhm,
think that's going to be the future of HIV. These long-acting medications, it's going to be easier and easier to maintain adherence because it's just less of a hassle to have to then taking a pill every day. I mean, I have to take a pill twice a day for another medical condition, and I like probably 50% of the time I miss that second pill. So I understand it seems easy in the head, but like life is complicated and busy, and it's not always easy to do that. I get it. But that's the future of HIV. For me, that's exciting because, HIV doctors are really focused on getting people to be adherent to their meds and keeping them undetectable. But if we have these methods of medication delivery where it's super easy for people to be adherent to their meds, we can focus on these other issues, like the other medical problems that are happening,
mhm.
substance use, the loneliness, some of these other issues that are really impacting people's lives, instead of just only focusing on HIV. So I'm excited. I think this is, and I think it has a potential to potentially end the HIV epidemic because
Mhm.
it just makes it so much easier for people.
I'm just amazed at the twice 2 shots a year thing. That's encouraging. That's
Yeah.
truly encouraging.
And some of these are also in evaluation for PrEP, by the way. That medication is also being evaluated for use as PrEP. So again, instead of taking a pill every day to prevent
Mhm.
HIV, getting 2 shots a year, that would be great, right?
Wow, wow, it would be. There was a question in the comments about has the cost decreased of HIV meds,
Um,
or is it still
no.
prohibitive? Okay.
Yeah, it's stupidly ridiculous. I mean, but then, thankfully, I think we have we have like safety nets for that. You know, we have like Ryan White and some other AIDS drug assistance programs that can help people pay for their meds, and folks that make too much money to qualify for that but can't really still afford to pay the deductible. A lot of the pharmaceutical companies have patient assistance programs for their HIV medicines for those people. So if you didn't know about it, ask your doctor and see if you qualify, because that can save a lot of money for people.
Yeah, yeah, it really would, because I was surprised when I saw just the PrEP medication alone. It wasn't cheap. It
No.
really was not cheap.
No, it averages right now about 2,500 to about 3,500 a month for HIV medications. The injectables are going to be more
Hmm.
expensive than that. So I think that the current cost of it is somewhere between $5,000 to $6,000 a month. So these are ridiculously expensive medicines that people have to take for the rest of their lives. You know, like at least until we get functional cure. But until then, um, I am hoping. So some of these medicines, like the current Truvada, which is the older or the original PrEP, is now generic. So I'm hoping that that the cost will go down for some of these medications to make it more accessible.
Awesome, awesome, awesome. So, and looking forward to the future, we were talking about medications that possibly maybe twice a year. Is there any other medical stuff on the horizon? Maybe less drug interactions or something like that?
So we're still looking for that magical, what we call a functional cure. And basically what that means is that the HIV is not gone from your body, but we are able to train your immune system to manage it so that you don't have to take medications for it every day. That is likely going to be accomplished with a combination of develop like a vaccine to help you develop more
Hmm.
antibodies against HIV, plus some other medication that kind of kicks out the HIV from infected cells and things like that. But but yeah, we don't really know. I mean, I think that's really the next thing. But apart from that, I don't know. It always amazes me, when I go to these conferences every year, the new things that come out. So we'll see.
Yeah, cool, 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 cool. I'm just, I've learned so much. you know, I truly have learned so much. I mean, I'm having ear issues. Um, some of the stuff I knew, but I didn't know about the twice a year medications. That is, wow. That's truly a game changer. But we won't, that not necessarily work unless we get the people to ask for the medication,
Yeah.
and they're not going to ask for the medications and let the doctors know what's going on with them. Because again, I just took an informal poll with my friends around my age, and many of them, they have never told their doctors their sexual orientation. And I just was really shocked by that. I was just really surprised. It was like, how can you go to a doctor, someone who you're paying to see,
Yeah.
and be scared to tell him about who you are?
Yeah.
I don't know. I I know it's a cultural thing. I realize all that, and a lot of people, particularly my age and older, they was never a thrill to go to the doctor anyway. So it was just a way to, it's another way of denial, and just saying I went, but really didn't talk about anything.
Yeah.
Well, Dr. Cat,
Yeah.
I want to thank you so much for your time. You've really taught so much. I know I've learned a lot of, I've learned a lot of different strategies going on in my head, thinking about, what can we as a, how can we talk to the people in the church, to help them, and how can we also start it be something that's going to be beyond the walls, that's going to help other people. So I thank you so much for this awesome conversation. I was looking forward to meeting the kids, but I guess we won't.
Thank you for having me. Again, I really do enjoy chatting with the community. So I like these experiences. If you ever need me to come talk about anything else, just let me know.
Sure,
And
sure.
I'll let the kids come on next time.
Oh, trust me, you'll be back. I was looking at the comments. Yeah, you'll be back. All right. Well, family, MCC Baltimore, I hope you've learned a lot. I hope that we've encouraged you, if nothing else, to be a little honest with your doctor. Talk, and have great talks with your doctor. It's one thing to go to your doctor and talk about high blood pressure or diabetes, but it's totally a different thing talking about talking about sex issues. And I wanted Dr. Karras on because a lot of times if I just say it, you're not going to hear me. But it's just so important that you share everything that's going on with you, with your provider, so your provider can help you. Okay? So that's going to be it for our chat and chew for the month of June. And I'll be excited to see what's going to happen in July. All right. See you later. Take us
Bye.
down, Pastor. Thank you, Garrett. Molly, Molly, Molly.
I am not a stranger to the dark. Hide away, they say, 'cause we don't want your broken parts. I learned to be ashamed of all my scars.